Hello, everyone. Professor Baig here. Welcome to the lecture on the endocrine system disorders. Before you watch this, I would suggest you watch the previous lecture on the anatomy and physiology of the endocrine system because that will help you understand these disease processes that we're going to cover in this lecture. Here are the learning objectives for this lecture. And this is an overview of what we're going to cover. Pancreatic disorders, thyroid disorders, parathyroid, pituitary and hypothalamic, and the adrenal gland disorders. So let's start with the big culprit, diabetes mellitus. There are two types, type 1 and type 2. So what is the difference? So diabetes mellitus is basically a chronic metabolic disorder. It's characterized by either a deficiency of insulin production, a decreased response to insulin by the body's cells, resistance, or a combination of both. Because insulin is essential for moving glucose from the bloodstream into the cells, where it can, the glucose can be used for energy to produce ATP. A disruption in the insulin function can affect the metabolism of carbohydrates, fats, proteins throughout the body. So there are two primary forms of diabetes mellitus, as we mentioned. Type 1 is an autoimmune disorder in which the body's immune system basically destroys the insulin-producing beta cells of the pancreas. So it's basically self-destructive, autoimmune process. This process is often triggered by by environmental factors, viral infections, and sometimes some people are just genetically susceptible to it. Now, as a result of this, the pancreas can no longer produce insulin, creating an absolute insulin deficiency. So what's going to happen in this case is that when the blood sugars are high, say for example, like I mentioned before in the previous lecture, I ate a big plate full of pancakes and lots of syrup on it, and then my blood glucose levels are high, but I'm a type 1, my pancreas cannot secrete the insulin, all right? They're not able to. There is no insulin for it to secrete. And so my blood glucose remains higher unless I use, insulin, inject insulin into me, right? So now patients with type 1 diabetes require lifelong insulin replacement therapy if they want to live. Okay, type 2 diabetes. It's much more common, develops when the body's cells become resistant, right, to the effect of the insulin. So the pancreas are secreting the insulin is traveling in the blood, it's getting to the target organ, but the cells are resistant to it. Now, over time, the pancreas are unable to produce enough insulin to overcome this resistance, because if the cells are resistant, it's going to keep sending insulin out, because remember, it's a feedback mechanism, right? A negative feedback mechanism. So it's going to keep producing this insulin, sending it there, and the blood glucose is still high. And so it's just going to consistently do that. And eventually it's going to say, you know what, I'm done. We're done. Live with it, right? So this basically results in relative insulin deficiency. Now, type 2 diabetes is strongly associated with obesity, physical inactivity, and metabolic syndrome. Although it was once primarily seen in older adults, it's increasingly diagnosed in younger individuals due to what? The rising obesity levels in the foods that we eat, right? A lot of fast food around us. So let's talk about the pathophysiology of diabetes, right? It basically follows a predictable sequence. When insulin levels are inadequate or ineffective, glucose cannot efficiently enter the cells. So this can have a lot of problems, right? Basically, you have that glucose, high levels of glucose hanging out in the blood called hyperglycemia or elevated glucose levels, right? Now, as this blood glucose rises, what's going to happen? You're going to have excessive glucose is going to spill into the urine, right? Because of the osmotic diuresis. Because now the kidney, as it's filtering the urine, because those big, gigantic glucose molecules, it's just going to pull more urine out, and you're going to have glucose in your urine, known as glucosuria. Now, the presence of glucose in the urine creates, like I mentioned, the osmotic effect. It pulls the water, and guess what it's going to pull with it? Electrolytes. And this results in polyuria, too much peeing, or excessive urination, and it can cause dehydration because the person is peeing a lot. It can cause electrolyte imbalances, and the peeing a lot can also cause polydipsia because that's your body's natural response. If you're excreting a lot of urine, it's going to protect you by making you feel thirsty. So you're going to feel very thirsty, which is polydipsia. Now, at the same time, because cells are unable to access glucose for energy, because remember, the insulin was supposed to push that glucose into the cells to make energy. So what's going to happen if there's no energy in the cells? It's going to cause fatigue, right? It's basically starving the cells, right? Despite the high blood glucose level, the cells are still starving for energy. And this can, besides causing a lot of fatigue, it can cause polyphagia, hunger, because what do people feel when they are starving? Hungry, polyphagia. So now these symptoms, polyuria, polydipsia, and polyphagia, are often referred to as the three P's of diabetes. Now, in severe insulin deficiency, particularly in type 1 diabetes, the body begins to break down fat and protein source for energy because it needs energy, right? What is the job? One of the jobs of the cells is to provide energy, right? Form ATP. Now, this process is known as lipolysis, right? Basically, it produces ketones as a byproduct. So it's breaking down fat and protein. And it's called lipolysis, and ketones are the byproduct. Now, when these ketones accumulate in the bloodstream, right, they create metabolic acidosis, which is also known as diabetic ketoacidosis, or DKA, which can become life-threatening if not treated promptly, right? Immediate insulin drip, fluids, dilute that sugar, push it into the cells. Now, clinically, patients with both types of diabetes commonly experience three Ps. Both types actually experience the three Ps along with fatigue and blurred vision. These are the common signs. Now, patients with type 1 will often initially present with weight loss, irritability, signs of ketoacidosis, including fruity or acetone smelling breath, deep, very deep, rapid respirations, known as the Kussmaul respirations. Now, patients with type 2 diabetes often have a more gradual onset of symptoms, right? So many, because, the pancreas are still pushing out some insulin, the cells might still be taking in some insulin, the glucose might still be getting pushed into the cells a little bit, but it's just chronically, going to become less. Now, many of them remain undiagnosed for years, and because they don't realize, that fatigue or the polyphagia or the polydipsia or the pain is from diabetes, right? So they usually present with slow healing wounds, right, or recurrent infections. A female might come in with recurrent, UTIs or fungal infections like yeast infections, or somebody might come in with wounds that are not healing, right, or itchy skin. So this is when they find out, oh well, it's like that because you have type 2 diabetes, right? So diagnosis is confirmed through lab testing, a fasting blood glucose level of 126 milligrams per deciliter or greater or more on more than one occasion is a diagnostic for diabetes, right? A glucose tolerance test, which, basically they drink a liquid, a substance with a lot of sugar in it, high levels of sugar, and 2 hours later they test to see how well the body tolerated it. That's also a diagnostic test for type 2 for diabetes. The HbA1c test provides information about average blood glucose over the previous 8 to 12 weeks. It's commonly used to monitor long-term management of diabetes, right? Urine analysis, for example, the reason why I mentioned that is because, for example, it basically is the average of 8 to 12 weeks. Now, one of those days and one of those weeks, or a few days and a few of the weeks, somebody's blood sugar might have been in the 300s, right? And that's not good. It's not good. It destroys vascular system and the organs. But some days that might have been really low. So the HbA1c is basically giving you an average of 8 to 12 weeks. So urine analysis would also reveal glucosuria, glucose in the urine, ketonuria, which can indicate poor glucose control or developing ketoacidosis. I know in the past, before all these fancy diagnostics were, invented, sometimes nurses would smell the urine. I even heard of stories of nurses tasting the urine to see if it's sweet, which, yeah, I don't think happens anymore. Now, treatment focuses on maintaining the blood glucose levels within a target range to prevent both acute and long-term complications. Diet and regular exercise, foundational components of treatment for everybody. Exercise improves glucose uptake by the muscle cells, and which helps to reduce insulin resistance. So basically, the muscles will take up more of the glucose and basically comes out of the blood because the muscles are uptaking it. Now, patients with type 2 diabetes, they're treated with oral medications such as metformin. That's the standard, right? That's the first, drug of choice by doctors. They're often prescribed that to reduce the insulin resistance because that's what metformin helps with. It reduces the resistance to the insulin. So this can help with, and it also actually helps with decreased glucose production by the liver. So other medications that may stimulate the pancreas to produce more insulin. For patients with type 1 diabetes or for some patients with advanced type 2 diabetes, insulin replacement therapy is absolutely necessary because insulin is a protein that would be destroyed during digestion. So basically, if you were to take a bottle of insulin and say, okay, I'm just going to drink it because I don't like injecting it, it's not going to work. It's just going to be destroyed during digestion. So it must be administered subcutaneously or through an insulin pump intravascularly. So then, most important thing to remember is diabetes mellitus. Diabetes mellitus results from insufficient insulin activity leading to hyperglycemia, cellular starvation, and widespread metabolic disturbances. Understanding this pathophysiology will really help explain a lot of the classic symptoms and complications that we see in patients with diabetes, and it would also help to, uh, evaluate treatment strategies used to help with this disorder. Like the medications for diabetes basically include your, focus on correcting either absolute insulin deficiency seen in type 1 or insulin resistance seen hallmark sign of type 2. Now, because the underlying cause is different, treatment strategies will vary between the two conditions. So let's begin with type 1. In type 1, the immune system destroys the insulin production beta cells of the pancreas, resulting in little or no insulin. Because the body cannot make insulin, patients require lifelong insulin replacement therapy. Then you have insulin. Since insulin is a protein, it would be broken down by the digestive enzymes if taken by mouth. Therefore, the insulin must be administered by subcutaneous injections or delivered intravenously through an insulin pump. Sorry, I can't talk right now. Insulin pumps provide a steady infusion of insulin and can help improve blood glucose control. Now, there are several types of insulin that are available. You have the rapid acting, the short acting. Basically, insulins begin working quickly and are often used around mealtime. So if you're going to eat that big meal with a bunch of pancakes, better inject that insulin because your blood glucose is going to be high in the blood, and this works rapidly within 10 to 15 minutes and helps push the glucose into the cells, right? Intermediate acting insulins basically provide coverage for longer periods of times, while long-acting insulins can last up to 24 hours and help maintain stable baseline or basal insulin levels throughout the day. So basically, we're trying to mimic, how an average healthy person's body would, you know, manage the glucose in the blood. And so that's what the insulins do. Basically, take it during the meals to help maintain it right then, which the body would have done if, everything was okay. And then in between meals to help maintain blood glucose then, which your body would do through its negative feedback mechanisms. And then the long-acting insulin just helps keep that basal insulin, blood sugar levels low. Okay, now for patients with type 2, treatment begins with medications that improve the body's response to insulin. For example, metformin, as we mentioned, it's typically the medication that is prescribed. It decreases insulin resistance and also reduces glucose production by the liver, because remember, the liver stores the extra glucose. So when your body is starving or is low in glucose, it pushes it out, right? Sulfonylureas and meglinotides stimulate the pancreas to release more insulin. The TZDs, I can never pronounce it, but the TZDs improve insulin sensitivity in the body tissues. The DPP4 inhibitors help regulate insulin and glucose secretion. And the GLPs, which have become very popular in the market, the GLP-1 receptor agonists, basically slow digestion and improve glucose control. The SGLT2 inhibitors work through the kidneys by preventing glucose reabsorption during the kidneys, urine production, and allows excess glucose to be excreted in the urine. Now, although many patients with type 2 diabetes can initially manage the condition with lifestyle changes and oral medications, some may eventually require insulin therapy if they do not have good glycemic control. So it's really important to teach, people with diabetes about, glycemic control, lifestyle changes, because they can actually reverse their HbA1c by just making lifestyle changes and oral medications, and eventually may not even need those oral medications, right? So, but in cases of severe hypoglycemia, also known as, insulin shock, an unconscious patient, if they cannot, you know, the bottom section, sorry, I kind of jumped the gun there. So the bottom section basically highlights emergency medications, right? It's used for acute diabetic complications. In case of severe hypoglycemia, also known as insulin shock, and an unconscious patient cannot obviously safely consume oral glucose. I mean, we can't tell somebody, hey, if you're in, insulin shock or you're extremely hyperglycemic, they're not thinking right, or they're not even conscious, here, take this glucose tab. No, in those situations, glucagon injections or IV glucose may be administered to rapidly raise that blood glucose levels. And when a patient has IV access, they're also given dextrose, D50 through the IV. Every hospital has a protocol for it. Now, conversely, with DKA, requires a different treatment approach. Management includes insulin administration along with aggressive fluid and electrolyte replacement to correct the dehydration and metabolic acidosis and any imbalances that they may have. The key point to remember here is that diabetes medications work, through different mechanisms, but all share the same goal, which is what? Maintaining blood glucose within a safe range and preventing both acute and long-term complications of diabetes. So these cheat sheets, please print these out. They will help you remember all this information. Now let's talk about thyroid disorders, right? We have hypothyroidism and hyperthyroidism. The thyroid gland plays a critical role in regulating metabolism by producing two hormones, T3 and T4. These hormones influence almost every cell in the body by regulating energy production, oxygen consumption, growth, and metabolism. The production of thyroid hormones is controlled through a hormonal axis involving the hypothalamus, anterior pituitary gland, and the thyroid gland. The hypothalamus releases the thyrotropin releasing hormone, or TRH, which stimulates the anterior pituitary gland to release thyroid stimulating hormone, or TSH. Then the TSH, as the name suggests, stimulates the thyroid gland to produce T3 and T4. So it's like this, this entire loop, this process. Under normal circumstances, a negative feedback mechanism, like we talked about earlier, maintains hormonal balance. Now, when T3 and T4 levels increase, they inhibit the release of both TSH and TRH, right? Because now the thyroid gland needs to stop, secreting T3 and T4. And so the TSH and TRH are going to decrease, which prevents the excessive secretion of this hormone. Now let's first discuss hyperthyroidism, also known as thyrotoxicosis. Hyperthyroidism occurs when the thyroid gland, obviously, produces too much thyroid hormone, excessive amounts of it, right? It results in a state of hypermetabolism. The most common cause is Graves' disease. This is an autoimmune disorder in which the TSH, the thyroid stimulating immunoglobulins, or the TSI, continuously stimulate the thyroid gland, right? They're constantly stimulating. There's nothing, it's not decreasing. And so now this causes the gland to enlarge and overproduce thyroid hormones despite the normal feedback mechanisms, right? So hyperthyroidism can also result from toxic nodules or adenomas, cancers that function independently of normal hormone control. Now, because metabolism is accelerated because of hyperthyroidism, patients often experience tachycardia, increased blood pressure, heat intolerance, right? They can't tolerate the heat. They're always hot, right? Tremors, weight loss, despite the increased appetite. They'll eat a lot, and then because their metabolism is so fast, they lose the weight. And so they appear very skinny. And they have a lot of diarrhea because your gut is overstimulated, so the peristalsis is really fast. So it just kind of increases everything, right? So one of the hallmark signs of the Graves' disease is the exophthalmos, or the protruding eyes. You'll see those eyes punched out, in the picture that was in the previous slide, which occurs due to the increased tissue growth behind the eyes. Remember, everything is excessive now, right? A serious complication of hyperthyroidism is thyrotoxic crisis. It's also known as a thyroid storm, right? More commonly known as a thyroid storm. Now, this is a life-threatening emergency in which thyroid hormone levels become extremely elevated. They're often triggered by infection, surgery, trauma, or severe stress. See, we're going to find out how severe stress can be on our body, right? It can cause a lot of problems, right? So let's control that stress, guys. Relax. Okay. So diagnosis is typically confirmed by lab findings, elevated T3 and T4 levels, and suppressed TSH levels, right? Because why? There's a lot of T3 and T4, so thyroid stimulating hormones are not needed, right? Because you have enough of it there. So treatment would include anti-thyroid medications to reduce hormone production, radioactive iodine therapy to destroy overactive thyroid tissue, or partial or total thyroidectomy to remove that gland. Now let's talk about hypothyroidism. Now, this is characterized by inadequate thyroid hormone production, which results in a state of hypometabolism, right? Everything is going to be slow. One of the most common causes is Hashimoto's thyroiditis. It's also an autoimmune disorder in which the immune system gradually destroys the thyroid tissue. So now if you don't have thyroid tissue, guess what we're not going to have, right? So other causes include iodine deficiency, complications following thyroid surgery, and congenital thyroid disorders. Now, because the metabolism has slows down with hypothyroidism, the patient commonly experiences bradycardia, and instead of heat tolerance like in hyperthyroidism, cold intolerance. So they're always cold. They're always feeling cold. And then they gain weight because the metabolism is slow. It's like the complete opposite. And they're not energetic and high energy. They're fatigued. They're lethargic. And because the peristalsis in the stomach is going to slow down because everything is slow, right? So they're going to have constipation, and they're going to have also brittle hair. Now, these symptoms reflect general slowing of the body's physiological process. Now, in severe cases, patients can develop myxedema, a condition characterized by non-pitting edema, facial puffiness, thickening of the tongue and tissues. If it's not treated, myxedema can progress to myxedema coma. slow down, right? Go into a coma. A life-threatening emergency marked by profound hypotension, decreased mental status and loss of consciousness. Now, the diagnosis is based basically on lab findings. What are we going to see? We're going to see low T3 and T4 levels. In primary hypothyroidism, where the problem originates within the thyroid gland itself, right? The TSH levels are often elevated, right? As the pituitary attempts to stimulate the failing gland. Because remember, it's a negative feedback mechanism. It's throwing out that stimulating hormone to stimulate the T3 and T4, but it's not getting stimulated. And so there's not enough thyroid T3 and T4 in the blood. And so the TSH is going to keep getting pushed out into the blood. And so the TSH levels are going to be high, right? Remember, in hyperthyroidism, they were low, right? Treatment consists of lifelong thyroid hormone replacement therapy. Most commonly, it's usually patients are, prescribed levothyroxine, initial treatment, which restores normal hormone levels and metabolic function. Now, the key point to remember in this is hyperthyroidism results in excessive thyroid hormone production and hypermetabolic state, while hypothyroidism results in insufficient thyroid hormone production and hypometabolic state. So early recognition, treatment are super important to prevent serious complications like the thyroid storm or myxedema coma. Okay. Now, another thing with the thyroid is the goiter. The goiter is an enlargement of the thyroid gland that appears as a swelling in the front of the neck. It can occur in both hypothyroid and hyperthyroid disorders. The endemic goiter is typically associated with hypothyroidism and results from iodine deficiency. Low iodine levels reduce thyroid hormone production. This can lead to increased TSH secretion. So over time, this persistent stimulation causes the thyroid gland to enlarge. So the toxic goiter is associated with hyperthyroidism. This occurs when excessive stimulation is causing the thyroid gland to overproduce the hormones and it enlarges. So treatment depends basically on the underlying cause, whether it's hypo or hyper, the size of the goiter. Options could include medications, radioactive iodine therapy, or surgical removal of part or all of the thyroid gland. So important thing to remember is the goiter is a thyroid enlargement caused by chronic stimulation of the gland, or it can occur in both hypo and hyperthyroidism. And you see this in patients. If you just Google a picture of somebody with the goiter, you'll see what it looks like. So now let's talk about the parathyroid glands. These are the smallest endocrine glands in the body and are located on the posterior surface of the thyroid gland. Their primary function is to secrete parathyroid hormone or PTH, which plays a critical role in maintaining, guess what? Calcium balance. So the PTH basically increases blood calcium levels by stimulating calcium release from the bone, increasing calcium absorption from the GI tract, and promoting calcium reabsorption in the kidneys. So at the same time, it increases phosphate excretion. Because remember, they have an inverse relation, calcium and phosphate, right, in the urine. Because calcium is essential for nerve conduction, muscle contraction, and bone health, disorders of the parathyroid glands can have widespread effects throughout the body. So let's begin with hypoparathyroidism, right? This disorder occurs when there is a deficient amount of PTH, which results in hypocalcemia and hyperphosphatemia because remember, they're inverse relationships. The most common cause is accidental damage or removal of the parathyroid glands during a thyroid surgery. Other causes include congenital absence of the glands, radiation exposure, autoimmune disorders, and severe magnesium deficiency. Now, the low calcium levels increase nerve and muscle excitability because remember, calcium calms, remember. So if there's low amounts, then there's excitability in the nerve conduction, right? Muscle spasms and stuff. So as a result, the patient will develop tetany, muscle spasms, hyperreflexia, two classic signs, as we mentioned in the A&P lecture, Chvostek and Tresel sign. Then additional symptoms will include tingling around the mouth and fingers, seizures, because remember, it's like excitable seizures, remember that? Laryngeal spasms, dry skin, hair loss, dental abnormalities, and cataracts. Cardiac effects would include weak contractions, arrhythmias, and hypotension because the lack of calcium, which is needed for muscle contraction, the heart will have arrhythmias. Diagnosis is based on low calcium and PTH levels, parathyroid hormone levels within and elevated phosphate levels. Right? Treatment typically involves lifelong calcium and vitamin D supplementation to maintain normal calcium because vitamin D helps absorb the calcium. Now let's discuss hyperparathyroidism. Parathyroidism, this is characterized by excessive secretion of the PTH hormone and results in hypercalcemia, right, or elevated blood calcium levels. Now remember, we said calcium calms, so when you have too much of it, what's going to happen? Now, primary hyperparathyroidism, is most commonly caused by benign adenomas or gland hyperplasia. It's in your cellular lecture. We talked about hyperplasia, right? Secondary hyperparathyroidism develops as a compensatory response to vitamin D deficiency, right? It's deficient, so it's trying to compensate. Now, tertiary hyperparathyroidism, it occurs when there's a prolonged stimulation, causing the glands to become autonomous and continue producing excessive PTH even after the original cause has been corrected. Remember the negative feedback mechanism? It would have corrected it and then it would stop, but over here it's not stopping. And so it keeps throwing out that PTH into the blood and stimulating the parathyroid hormone. Now, elevated calcium levels will decrease the nerve excitability. Now, it's calcium comes too slow, but can cause significant skeletal and renal complications because increased bone reabsorption can lead to osteoporosis, bone pain, and even pathological fractures. Now you have too much calcium there, right? High calcium levels also increases the risk of kidney stones, right? The calcification causes kidney stones, renal insufficiency, polyuria, and polydipsia, right? Polyuria because the excess calcium in the kidney is as it's excreting, it causes osmotic diuresis. And when you're diuresing a lot, then you're going to feel thirsty, right? So patients would also experience fatigue, depression, personality changes, headaches, constipation, nausea, vomiting, because everything is slowing down. You're feeling constipated. Your peristalsis is slowing down, so you're going to feel nausea and vomiting. Not even get vomiting as well. And anorexia. Cardiac manifestations include arrhythmias, bradycardia, hypertension, and forceful cardiac contractions. Diagnosis is confirmed through, basically calcium levels and PTH levels. Treatment focuses on basically correcting the underlying cause. And for primary hyperparathyroidism, a parathyroidectomy is often required because the problem is with the gland. So they'll remove it, right? Secondary hyperparathyroidism that's being caused by something else is basically treat the cause, right? Whatever is causing it, right? And most of the time, like we said, it's a renal disease or just correcting the calcium or vitamin D deficiencies. So basically the key point is hypoparathyroidism causes low calcium levels and increased neuromuscular activity, while hyperparathyroidism causes high calcium levels, bone loss, and kidney complications. Now, because calcium is very essential for normal nerve function and muscle contraction and cardiac function, maintaining the proper PTH regulation is critical for overall health because it can affect a lot of body systems. So now let's talk about the pituitary and hypothalamic disorders, right? So over here, we have the hypothalamus and the pituitary gland. They work together as a body's primary neuroendocrine control system. Together, they serve as the link between nervous system and the endocrine system, helping coordinate many essential body functions and maintain homeostasis. Now, the hypothalamus is located in the brain. Obviously, we all know that, right? And it plays a key role in regulating internal balance. Basically, it controls water balance, appetite, body temperature, sleep-wake cycles, and hormone secretions. So one of its most important functions is regulating the pituitary gland, and it does this through releasing and inhibiting hormones. So the pituitary gland, also known as the hypophysis, is located at the base of the brain, just below the hypothalamus. Although it's relatively small, it's often called a master gland. It does a lot because it controls the activity of a lot of the endocrine glands throughout the body, right? It's small but strong. right? Powerful. So the pituitary gland consists of two distinct lobes, the anterior pituitary and the adrenal hypophysis. This produces and produces and secretes hormones. For example, the growth hormone, thyroid stimulating hormone, adenocorticotropic hormone, follicle stimulating hormone, FSH, and luteinizing hormone, the LH. These hormones either act directly on the target tissues or stimulate other endocrine glands to release their hormones. So the posterior pituitary, the neurohypophysis, stores and releases hormones produced by the hypothalamus, including the ADH and oxytocin. We talked a little bit about this in our previous lecture on the ANP of the endocrine system. Now through these work together, basically, the hypothalamus and pituitary gland, and regulate growth, metabolism, reproduction, stress response, fluid balance, and a lot of vital functions. So remember that the hypothalamus directs the pituitary activity. So the pituitary gland can coordinate hormone secretion throughout the system. It's the master gland. Okay. So let's talk about, the pathophysiology of these pituitary disorders. Most pituitary disorders, they're caused by benign tumors known as pituitary adenomas. Although these tumors are not cancerous, they can still produce significant health problems because their location and effects on hormone production. Pituitary adenomas cause symptoms through two primary mechanisms, mass effect and hormonal effect. As the tumor enlarges, remember the hyperplasia, the metaplasia we talked about in our cellular lecture, what happens when the tissues enlarge and they push against other tissues and they stop the functioning because of their overgrowth. So patients could experience headaches, seizures, drowsiness because the pituitary gland sits just below the optic, chiasm, and an enlarging tumor can compress the optic nerve, and this can result in visual disturbances such as, hemianopsia, which is the loss of part of the visual field. So pituitary adenomas can also cause hormonal effects. Some tumors are functional, meaning they actively secrete excessive amounts of hormone. For example, growth hormone, right? Secreting adenoma can lead to disorders such as gigantism or acromegaly. In other cases, the growing tumor destroys normal pituitary tissue. This reduces hormone production. This can result in hormone deficiency, such as decreased ACTH secretion, which affects adrenal gland function. So the key point to remember is pituitary disorders typically result from benign adenomas that cause symptoms, through pressure on the surrounding structures or by disrupting normal hormone production. Then although the hypothalamic disorders are less common than other endocrine disorders, they can have widespread effects, obviously, right? Because the hypothalamus regulates a lot of critical body functions and controls the pituitary hormone secretion. So the most common causes of hypothalamic dysfunction are tumors and infections. This can damage the hypothalamus or interfere with its ability to send and regulate signals to the pituitary gland. So if there's no communication, the pituitary gland can't do its job. Now, because the hypothalamus controls a lot of homeostatic processes, remember hypothalamus is the boss of what? The vital signs, water balance, all these things, right? Symptoms can affect a lot of body systems. Patients may experience insomnia due to disruption of normal sleep-wake cycles, hypothermia because of impaired temperature regulation, anorexia due to altered appetite control. So the hypothalamus also communicates with the pituitary gland, through specialized vascular connections. So damage to these vascular connections from uncontrolled hypertension or, glucose levels. This can disrupt hormone signaling because the vascular system is damaged. And this can cause secondary hormone deficiencies because now it can't send the signal. So for example, impaired signaling may reduce the secretion of growth hormone or growth hormone leading to growth abnormalities or decrease antidiuretic hormone or ADH. This can cause fluid balance disorders such as diabetes insipidus. So the key point to remember is because the hypothalamus regulates both homeostasis and pituitary function, disorders affecting this region can cause a lot of problems, including neurologic, metabolic, and endocrine. Here is a cheat sheet, on growth hormone. Please review this. Basically, the growth hormone is produced by the anterior pituitary gland, plays a critical role in regulating growth, metabolism, tissue development. Disorders can cause either deficiency or excess in growth hormone. Remember, we said that for endocrine disorders, hormones is either excessive or decreased. So each can cause separate manifestations. So basically, deficiency can cause pituitary dwarfism, right? That's where you see people who are dwarfs, right? This condition results from inadequate secretion of the growth hormone or deficiency of the somatotropin releasing hormone from the hypothalamus. Common causes include pituitary adenomas, vascular damage to the pituitary gland, or other conditions that impair hormone production. Children with GH deficiency develop proportionate dwarfism, meaning all of the body parts remain in normal proportion, but overall growth is reduced. So you'll see the long hands and stuff, but the overall growth is reduced. Right? So now, unlike some genetic forms of dwarfism, intelligence is usually normal. It's just the body parts. However, affected individuals often experience delayed skeletal maturation and delayed puberty. Now, the treatment for this consists of growth hormone replacement therapy, which is the most effective when initiated before the epiphyseal growth plates close during adolescence. So there's a certain time period, right, before adolescence that this can be effective. Early diagnosis and treatment are super important to maximize the growth potential and fix the problem. Now let's discuss growth hormone excess, which can result to gigantism or acromegaly, depending on when the excess hormone secretion occurs. In most cases, growth hormone excess is caused by a pituitary adenoma that basically secretes excessive amounts of growth hormone, right? When this excess GH occurs before puberty and before the epiphyseal plate closure before adolescence, it can cause gigantism. Because the growth plates remain open, excessive skeletal growth occurs, resulting in extreme height, sometimes reaching 8 to 9 feet tall, right? So when GH excess develops but if it develops after the epiphyseal closure, the result is acromegaly. So this is after adolescence, basically. So since the bones can no longer grow longer, they instead become thicker and broader. Patients develop enlarged hands and feet, coarse facial features, and protruding jaw known as prognathism. Soft tissue enlargement is also common, including enlarged tongue, macroglossia, and increased activity of the sweat glands, right? So you're constantly sweating. Over time, acromegaly can lead to serious complications. And, because it can lead to hypertension, diabetes, mellitus, and nerve compression syndromes. This occur when the thickened bones compress surrounding nerves. Diagnosis of this involves measuring elevated growth hormone levels and using MRI to identify the presence of a pituitary adenoma. Treatment will focus on either reducing the growth hormone secretion and removing the underlying tumor, or, and providing growth hormone therapy. Surgery and radiation therapy are also used to shrink and remove the adenoma. Medications such as bromocriptine, a dopamine agonist, can also help suppress the GH secretion. In some cases, the treatment can damage normal pituitary tissue. This can lead to panhypopituitarism, a deficiency of multiple pituitary hormones. Basically, that's what it means. These patients require lifelong hormone replacement therapy, including thyroid hormones, sex hormones, glucocorticoids such as hydrocortisone. So basically, the key point is GH deficiency causes proportionate dwarfism, while excessive GH causes gigantism in children and acromegaly in adults. The timing of the excess GH secretion relative to the epiphyseal plate closure determines which disorder develops. Now let's talk about the antidiuretic hormone. ADH abnormalities are ADH is basically produced by the hypothalamus, released from the posterior pituitary gland. Its primary function is to regulate water balance. The name says, antidiuretic hormone. It promotes water absorption in the kidneys. Disorders of ADH secretion can result in either too little or too much water, right, being retained by the body. Let's begin with ADH deficiency, when you don't have enough antidiuretic hormone. This causes diabetes insipidus, DI, right? So what's happening? You don't have enough antidiuretic hormones, so what you're going to do? You're going to have a lot of osmotic diuresis. And so people usually will pee a lot. This is diabetes insipidus. This occurs when there is inadequate ADH secretion from the posterior pituitary, and the kidneys fail to respond appropriately to the ADH. Causes could include head trauma, brain surgery, infections, tumors, aneurysms, genetic abnormalities. Some medications can also interfere with kidney response to ADH, and this can result in nephrogenic diabetes insipidus. So without adequate ADH activity, the kidneys are unable to conserve water, right? So this causes patients to produce extremely large volumes of dilute urine, right? They're just large volumes of the urine, often 8 to 12 liters per day. This condition, known as polyuria, right? The excessive fluid loss triggers intense thirst, polydipsia. The patient's body attempts to replace the lost water. If fluid intake cannot keep up with fluid losses, patients will develop severe dehydration, hypernatremia because they're losing a lot of fluid. So the sodium in the blood is increased, and increased serum osmolality because the blood is not dilute enough. Diagnosis is based on excessive urine output, low urine concentration, elevated serum osmolarity. Treatment would typically will involve ADH replacement therapy along with adequate fluid replacement so they don't get dehydrated. So now let's quickly discuss ADH excess, known as syndrome of inappropriate antidiuretic hormone, and that is called SIADH. This occurs when excessive amounts of ADH are released. So when you have too much, you're going to hold it all in, causing the kidneys to retain too much water. Common causes include certain cancers, particularly lung cancer, central nervous system disorders such as meningitis or head trauma, and triggers such as surgery, stress, anesthesia, medications, including antidepressants, narcotics, and NSAIDs. That's why we say people who are on antidepressants sometimes do, gain weight, right? As water is retained, the blood becomes diluted. There's too much fluid, right? So the blood becomes very diluted. So then you have dilutional hyponatremia. You have too much diluted blood, and so your sodium is low in the serum. At the same time, the kidneys continue to produce highly concentrated urine. So patients would experience symptoms such as confusion, irritability, fatigue, muscle twitching, anorexia, and weight gain due to the water retention. So if hyponatremia becomes severe, you can end up with cerebral edema, and permanent neurological damage can occur because now you're retaining so much fluid, it's going to retain it around the brain. So treatment will basically focus on correcting the underlying cause, restricting fluids when appropriate, restoring electrolyte balance, diuretics to get rid of some of that water, and sodium supplementation because remember, water follows sodium, right? And so if they have sodium, then the body will, your kidney will excrete the urine. This could also help, basically reduce fluid overload. And it also corrects the hyponatremia because if the blood is too dilute, then sodium is low in it. And we don't want that, right? Because it can cause neurological problems. So key point being, DI results from too little ADH activity, causing excessive water loss and dehydration, while SIADH results from excessive ADH activity. This causes water retention and dilutional hyponatremia. Both disorders significantly disrupt fluid and electrolyte balance and require prompt recognition and treatment. Now let's talk about the adrenal disorders. The adrenal glands are located on top of each kidney. It consists of two distinct regions, the adrenal cortex and the adrenal medulla. The adrenal cortex produces mineral corticoids and glucocorticoids and androgens, while the adrenal medulla secretes epinephrine and norepinephrine, hormones that support the body's stress response, as we mentioned in our A&P lecture. So one of the most important disorders of the adrenal cortex is Cushing syndrome. This is characterized by excessive levels of glucocorticoid hormone cortisol. Cushing syndrome results in excessive ACTH secretion, often caused by a pituitary tumor, a tumor of the adrenal cortex, itself or ectopic hormone production by certain cancers, such as lung cancer. Now, this can also occur as a iatrogenic condition following, for example, from medications, right? Long-term glucocorticoid medications. Excess cortisol basically has widespread effects throughout the body, right? It promotes the breakdown of proteins and muscles, connective tissues, leading to muscle wasting and thinning of the skin. Cortisol also increases glucose production by the liver. This causes insulin resistance, contributing to elevated blood glucose levels. Now, patients often develop characteristic physical changes, including, truncal obesity, a rounded moon face, a buffalo hump, which is accumulation of fat on the upper back and neck. Other common findings include purple stretch marks, easy bruising, osteoporosis, and increased risk of fractures. Now, because cortisol suppresses immune and inflammatory responses, patients are also more susceptible to infections because now they're immunocompromised, right? They have a suppressed immune system. So systemically, patients may experience hypertension, hyperglycemia, glucose intolerance. Diagnosis based on lab findings such as hyperglycemia, glycosuria, hypokalemia, then these are confirmed by testing, which often includes measurement of urinary free cortisol or late night salivary cortisol levels, as we mentioned in our, A&P lecture. So all of these will diagnose Cushing syndrome. Now the treatment depends on underlying cause. Tumors require surgical removal, while patients with medication-induced Cushing syndrome may have their glucocorticoid doses gradually tapered. Abrupt discontinuation of the glucocorticoids can suppress the normal adrenal function, and this can lead to adrenal insufficiency. So we don't do it abruptly, it's tapered down. So key point, Cushing syndrome results from excessive cortisol, and it's characterized by central obesity, muscle wasting, skin changes, hyperglycemia, hypertension, and increased susceptibility to infection. Diagnosing it early and treating it are extremely important to prevent long-term complications. So let's move on to Addison's disease. This is also known as adrenocortical insufficiency. This occurs when the adrenal cortex fails to produce adequate amounts of glucocorticoids or mineralocorticoids and androgens. And because these play, their critical roles in stress response, fluid balance, and metabolism, you can have widespread effects. The most common cause of Addison's is autoimmune destruction of the adrenal cortex. Other causes include adrenal hemorrhage, infections such as TB or histoplasmosis, and tumors that damage the adrenal glands. Now, when adrenal hormones, when these levels decline, the hormone levels, the body loses its ability to respond effectively to stress and maintain metabolic and electrolyte balance. And this can cause, weakness, fatigue, weight loss, and decreased appetite. One of the hallmark signs of Addison's disease is hyperpigmentation or darkening of the skin. This occurs when low cortisol levels stimulate increased secretion of ACTH from the pituitary gland. Now, this elevated ACTH stimulates melanocytes. This causes darkening of the skin, particularly in the skin creases, scars, and buccal mucosa. Patients may also develop orthostatic hypotension, fasting hypoglycemia, hypernatremia, and hyperkalemia. All of these due to the deficiency in cortisol and aldosterone. A serious complication from this is Addisonian crisis, a life-threatening emergency. This is characterized by hypotension, severe hypotension, nausea, vomiting, diarrhea, dehydration, leading to shock. This crisis is often triggered by physical or emotional stress, trauma, infection, or the abrupt discontinuation of hormone replacement therapy. Diagnosis basically are, the clinical findings and lab evidence of adrenal hormone deficiency. Treatment would be lifelong hormone replacement therapy, most commonly with hydrocortisone, and when needed, mineralocorticoid replacement. This is the reason why we should always tell our patients to never stop medications abruptly. And they should increase their medication dosage, And so the key point being, Addison's disease results from adrenal hormone deficiency and is characterized by fatigue, weight loss, hyperpigmentation, hypotension, electrolyte imbalances, and a risk of life-threatening Addisonian crisis. And once again, early recognition and treatment are the key. Now let's talk about pheochromocytoma. This is a rare tumor. We also kind of talked about this in our cancer lecture. This is a rare tumor of the adrenal, medulla that causes excessive production of catecholamines, specifically epinephrine and norepinephrine. Although most, pheochromocytomas are benign, they can have serious cardiovascular consequences if they're not treated. The tumor develops within the adrenal medulla, and approximately 10% of the cases are malignant. Because the adrenal medulla is responsible for producing the body's stress hormones, the tumor causes excessive, uncontrolled release of catecholamines. This excess catecholamine release secretion can cause prolonged flight or flight response, right? Resulting in widespread stimulation of the sympathetic nervous system. That is just, that's just going crazy, right? Fight or flight response 24/7. The hallmark sign is severe hypertension, which can be, which may be persistent or occur in sudden episodes known as paroxysmal hypertension. Patients commonly experience headaches from the elevated hypertension, palpitations, tachycardia, excessive sweating, pallor, and glucose intolerance. These symptoms occur because basically catecholamines increase heart rate, blood pressure, metabolic rate, and blood glucose levels. Certain factors can trigger or worsen these symptoms, including exercise, emotional stress, caffeine. Let me include energy drinks, right? Tyrosine-rich foods, and anesthesia induction. Diagnosis involves basically measuring catecholamine levels or their metabolites and identifying any tumors through imaging. Because this is such a is a potentially curable cause of hypertension, treatment typically involves surgical removal of the tumor. Blood pressure is usually stabilized with medications before surgery to reduce the risk of severe cardiovascular complications during the tumor removal. Now, the key point is that this is a catecholamine secreting tumor of the adrenal medulla that causes episodic or persistent hypertension, tachycardia, sweating, headache. Surgical removal is often curative when the tumor is identified and treated in time. And that is it for a very long endocrine lecture. Sorry guys, there's just a lot of hormones and a lot of glands we needed to talk about. And that would end it. And for those of you who've been in my lectures before, you are familiar with Mr. Carbo. Obviously, he's having tremors and wondering if his blood sugar is too low or he has too much caffeine. And Mr. Carbo, you're just being jazz. Okay, and that is it.